and that will be the last CME of the year, and that will be a pediatric topic for those of you needing the pediatric specialty CMEs. So the credits for the last 8 CMEs are ready. Remember, once you've done the feedback, the CME certificates will automatically come. The next 5 CMEs will be ready by the end of the week. For those of you that would have missed some of the meetings, the last 10 meetings were recorded, so you can do it on the Sunshine Learner website and still claim the CMEs. Today's speaker is not only an emergency room consultant, but he's also an author. Dr. Robert Roper graduated with honors from medical school in 2007, and then he completed his CAMC registration that same year on into 2008. He worked in Jamaica from 2008 to 2010, and then he joined us here in the Bahamas, where he completed his DM in emergency medicine. He presently works as a consultant in emergency medicine here at the Princess Margaret Hospital, as well as Doctors Hospital. He also holds a diploma in emergency ultrasound since 2019. So a little bit about his book. The name of his book is Mommy, Where Do Babies Come From? It introduces the concept of traditional reproduction in a manner that's ideal for the preschooler. And if you Google or go on Amazon and look at Dr. Roper's book, the reviews are actually quite impressive. And some of them, the author used poetic verse to tell the story. So Dr. Roper has an interest in poetry. Most eloquently packaged explanation of a usually uncomfortable question. The verbiage is melodious, and it goes on and on. Now, let's welcome, in his own words, Dr. Roper, who says he is the father of 1 child, husband of 1 wife, and author of 1 book. Thank you, Dr. Roper, and welcome.
Thank you, Dr. Black, for inviting me to actually present. I hope you guys enjoy the presentation. So, shortness of breath, the ever-changing story. I have no financial disclosures. And so we usually like to start our case discussions or presentations with a case. So we have a patient, Mr. UF, he's 56 years old, had no medical illness and presented with swelling of the face, neck, and gums, legs, and associated shortness of breath. He attributed his symptoms to having ingested Chinese food like a week prior, noted the swelling, had 2-pill orthopnea, shortness of breath at rest and exertion, denied any difficulty swallowing, denied any fever, any cough, expectoration, hemoptysis, travel history, or ill contacts. He reported that he had a 20-pound weight loss over the past 2 years, but he said he was previously active. And he drank a cup of Guinness every other day. His vitals included a blood pressure of 153 and 102, a heart rate of 118, saturations of 96, but he was on a simple face mask at 5 liters. The emergency room physician documented that he had normal heart sounds, no murmurs, and had an elevated JVP. They also noted that he had crackles towards the base of his lungs, and his abdomen was soft but was not tender without any presence of organomegaly. The additional findings were reported by medicine when he was referred. So medical team reported that he had enlarged parotid glands, he had a few smooth cervical lymph nodes, he had an elevated JVD, so they agree with the emergency room in respect to that. They also noted that he had decreased air entry towards the bases, that he had crackles and stony dull percussion. They said that he had hepatomegaly and reported that he had questionable splenomegaly. So this was the x-ray that was obtained. So they have all this information prior to examining the patient. So this is the information that was obtained in terms of his chest x-ray. On the x-ray, you're seeing that he has evidence of cardiomegaly. You're seeing that he has redistribution, but you're also seeing that he has loss of the costophrenic angles. His ECG was also conducted and noted that he had inferior lateral wall ischemic changes as demonstrated by T-wave inversions. He also had evidence on his laboratory findings of a creatinine of 1.8, which was marginally increased, and a troponin of 0.11. So this is all the information that you will have if you are the physician coming down, examining this patient to determine what is the likely cause of his shortness of breath. And so perhaps your thought process may be that he has congestive heart failure, and that would be reasonable. Maybe he has a malignancy, pulmonary embolism, maybe he drank too much and has liver cirrhosis, or maybe in this environment, he has COVID-19. And so what is shortness of breath? Shortness of breath, or dyspnea, is the sensation of running out of air and not being able to breathe fast enough or deeply enough. And you have this interaction between peripheral and central receptors, chemoreceptors, mechanoreceptors in the upper airway, lungs, and the chest wall. So when we look at the epidemiology, we know that shortness of breath itself is not a diagnosis. And so you're not going to find a search that's going to tell you that the prevalence or the epidemiological data of shortness of breath is X or Y. And so I looked up the most common causes of shortness of breath. So congestive heart failure has a prevalence in the US of 5.8 million per year and 23 million per annum. Pneumonia represents 1.3 million per year of the visits to the emergency room. And pulmonary embolism has an approximate value of 10 million cases per year, but the true incidence is not known. And this is largely due to perhaps rule out protocols like the PERC rule, or utilizing the Wells score that risk stratifies patients, or that these patients are asymptomatic or have subsegmental pulmonary embolisms as well. What does our data show? So I was able to get the data from 2019 to 2020. And the only thing that these numbers are not adequately representing what is happening now, as far as I'm concerned. But congestive heart failure represents about 12 patients, 14 patients in total. And pneumonia represents 46 patients in total. But if you notice that of the 14 patients, you notice that 6 actually have died. And of the patients who presented with pneumonia, 12 have died. So there's still an increase in inherent morbidity or mortality associated with these pathologies in our setting. So going back to the pathophysiology, we spoke about the mechanoreceptors, that they're located in the airway, the trachea, the lung, and the pulmonary vasculature. We know that they are adapting stretch spindles that respond to volume. We know that they are irritant receptors in the airway itself. And when these are stimulated through the vagus nerve, they exhibit for us that we need to take a breath. We know that they are carotid bodies and aortic bodies, and they actually represent 15% of the driving force of respiration. So if your partial pressure for oxygen falls below 60, then chances are through the glossopharyngeal nerve and the nucleus tractus solitarius, you're going to be stimulated to breathe again. And we know that in the central nervous system that the pH is very sensitive and that hydrogen doesn't really cross the blood-brain barrier and that carbon dioxide is the only substance that is able to cross the blood-brain barrier. And once it does, it attaches to water, forms carbonic acid, and that dissociates, and ultimately hydrogen is released and it decreases the pH, which results in us stimulating the ventral surface of the medulla and also causing us to take a breath. We also know that apart from these peripheral and central responses, we have the higher cerebrum that gives us voluntary control of breathing. So when we look at the etiologies, we know that we can divide them into cardiac, pulmonary, and central. In terms of cardiac, you still have congestive heart failure, but you have coronary artery disease, arrhythmias, pericarditis, MI. In terms of pulmonary, you could have pulmonary effusion, metastatic disease, pneumothorax, pneumonia, asthma, COPD. And in terms of neuromuscular disorders in the central areas or aspirin overdose or other overdoses like opioids that may affect our breathing. So we take the signs and symptoms that were typically present and we utilize them to try and guide us as to what is the potential pathology this patient may have. So if they say that they have 3-pill orthopnea, you're going to think that they have congestive heart failure. If they say they have hemoptysis, you're going to think that they have lung cancer or pulmonary embolism. If they say they have dizziness or syncope, you're going to think it's a valvular heart disease. And if they say they on physical examination, they have wheezing or decreased air entry, you're going to think that they have asthma or exacerbation or pneumothorax. So having said all of that, there was a study that was done in 2016 in Asia, Australia, and New Zealand. And 3,044 patients were included in this study. And this was done over 3 72-hour periods in May, August, and October. And they found that approximately 80% of the patients who presented either can be categorized into respiratory, cardiovascular, or mixed. So essentially, what we need to do when a patient presents with shortness of breath, 8 out of 10 of the times, is either look at the heart or look at the lung. So we're going to take congestive heart failure since it has the highest prevalence of all of the pathologies that we've discussed thus far. And we're going to just go a little bit into the pathophysiology of a congestive heart failure. So we know that the heart has a responsibility to meet the metabolic demands. And when this metabolic demand is not met, then you have this cascade of elements that occur that result in heart failure. Decrease in the cardiac output will ultimately stimulate the baroreceptors. Once they're stimulated, you have tachycardia. When the cardiac volume drops, then you're going to have effect to the kidneys as well. And so the decreased blood flow to the kidneys will result in the production of renin, angiotensin, and aldosterone. I realize that you're not seeing my pointer. So the decreased blood flow will cause decreased blood flow to the kidneys, and you have release of renin, angiotensin, and aldosterone. So aldosterone will cause us to retain sodium in water. And you also have stimulation of the ADH, the antidiuretic hormones and aquaporins in terms of those being released and causing us to retain more water. The retention will cause increase in preload in an already overworked heart. But also you have angiotensin that is a potent vasoconstrictor. And that vasoconstrictor is going to increase the afterload. And the increase in tone in the afterload is going to cause a backflow that increases volume in our already low pressure system in the lungs that creates the symptoms and signs that we typically would find in a patient with heart failure. So bearing in mind those things, I just wanted to revisit the definitions of a few things. That sensitivity is your ability to detect a patient with a disease. Specificity is your ability to detect patients or say that a patient absolutely doesn't have it. So true positive sensitivity, true negatives is specificity. So we would typically utilize all these signs and symptoms for heart failure and say that they are very reliable. But in this little study in 2016, you'll find that orthopnea has a sensitivity of 22%, P&D 39%, fatigue 23%. The crackles, 78%. And the S3 Gallup only has a sensitivity of 13%. So ultimately, we're going to use the X-ray, which has a sensitivity of 50% in terms of detecting heart failure. So we utilize these different stages in terms of what the pulmonary capillary wedge pressure should be. And that in turn tells us whether or not the patient likely has, or what, what findings the patient should likely have. So you notice in the stage 1, they have redistribution and cardiomegaly. That is evident here. And in stage 3, they should have consolidation, pleural effusion, cotton wool appearance, which would mean that they have alveolar edema. I need to move this off my screen. And so when we think about that, why is my slide not moving? 1 second, please. If you were given this particular X-ray, you would say, fine, I noticed that this patient has cardiomegaly. I would agree. That the patient has redistribution, would also agree. That maybe they have obliteration of their cardiophrenic angle, also would agree. But what would you call this? Chances are in our setting, we'd call that patient has an associated pneumonia, when in fact, it represents that the patient had a grade 3 mitral insufficiency with pulmonary edema, predominantly on the right upper lobe, and that's caused by a vector flow of mitral regurg in the right superior pulmonary vein. So again, just to prove that X-ray is not a reliable tool as it pertains to diagnosing someone with shortness of breath. And so Ideally, you can utilize BNP and use their margins. If they're greater than 400 or 500 in some of the studies, you can say they have congestive heart failure. If they have less than 100, you can say that they don't. And if they're somewhere in between, then you really don't know. But we don't have BNP. And maybe you're going to say, let's use the pulmonary capillary wedge pressure to guide the process. But most patients aren't going to get pulmonary capillary wedge pressure. And let's say you're not sure, but you think that that patient may benefit from BiPAP, but we don't have BiPAP machines readily available to us. So what do? We take the history, which sometimes is unreliable, depending on the patient you have, or maybe they're uncooperative. The physical exam, which has poor inter-observer reliability or reproducibility, or the laboratory investigations, which sometimes may not be available, or they may mislead your process of diagnosis of the patient. So there has to be, and I unequivocally believe there has to be a better way. So I propose that we utilize the ultrasound machine. And so if you think of the ultrasound like a bat in the dark, shooting out an echo, trying to locate its next meal, and it knows how far the meal is, how big the meal is, its relationship to itself, its relationship to other objects that surrounds it. And that's pretty much what the ultrasound machine is doing. So you use acoustic impedance to determine the location, the depth, and the ability of those echoes to either be reflected or pass through an object. And so blood will appear black on the ultrasound machine. Most of the echoes are going to pass through. The liver has somewhat amount of reflection. Some of it is going to pass back to the actual probe and it's going to appear gray. The diaphragm is a highly reflective surface. Some of it is going to pass through, but most of it will be reflected through or back to the probe. And then in terms of solids like the bone or stone, most of it is going to be reflected back and it's going to cast a shadow. And if you base those principles and apply those principles to a patient who presents with shortness of breath, and you apply it onto the anterior chest wall, or you apply it onto the heart, or you apply it onto the anterior axillary line, looking at the liver and looking at the lung, or you apply it to the aorta, you're going to get at least some of the answers as what is the cause of their shortness of breath. So let's just apply it to the lung. We know that the lung, as we stated before, has a reflective surface. Most of the echoes are going to come back to the actual probe itself, but you're going to see the evidence in time of lung sliding. So you're going to see the visceral and parietal pleura moving as the patient takes a breath. And you're going to see these artifacts, which are actually Kelly A lines, and you're going to see them in intervals of equal distances. This is just a photo depiction depicting the same thing that we just spoke about. But what if they have absence of that lung sliding slide? Then you will notice that you'll have rib, you're looking again at the pleura, and you're looking that there's no movement. And if you carry it over to the B mode of the ultrasound, you'll see that it looks almost homogeneous, and this is called the barcode sign. So a patient comes in with shortness of breath, and they have, let's say, asthma. And they say, you know, I've used my inhaler, I've been admitted to the ICU, I've had multiple intubations, you put the probe on them and you see this, then you need to go no further than a chest tube. So what about congestive heart failure that we were discussing earlier? So we spoke about the pulmonary capillary wedge pressures and the fact that the pulmonary vasculature is a low pressure system. And if that low pressure system starts to get inundated with fluid, then it starts to manifest either on X-ray or on ultrasound. So what is typically utilized is the interlobular septum as reference from a histological standpoint. And these are usually 7 millimeters apart from each other. Excuse me. So when you place the probe on a patient, whether it be a linear probe, a phase array probe, a curvilinear probe, you should be able to quantify or see the interlobular septae as fluid starts to accumulate in the interstitium. What happens is that the septae actually comes closer to the anterior chest wall and you're able to see these curly B lines that you typically would see on X-ray. But as the fluid starts to fill up the alveoli, as the pulmonary capillary wedge pressure increases beyond 25, you start to have alveolar edema. And instead of you seeing that, the separation is 7 millimeters, this separation now becomes here and it becomes 3 millimeters. So the findings start to look more coalesce, or they start to merge. And we'll see that in the videos ahead. So again, normal curly A lines. As the fluid becomes into the interstitium because of hydrostatic pressures, you're going to start seeing the curly B lines. As the curly B lines become more prominent, then you can say that the patient is starting to develop pulmonary edema. And as they coalesce, you're going to say that they have alveolar edema. All right. So more 3 to 5 curly B lines will equate to pulmonary edema. Once they coalesce, you're going to say that they have alveolar edema. So 1 second again for me. All right. So this is showing the lung sliding. Let's play it again. The lung is sliding and you're seeing these flashlight type of image, which is be a curly B line. Once you see 3 or 5 of these in a single sector, and if you see it on multiple areas and they're symmetrical on the anterior chest wall, the axillary line, and posteriorly, then this patient has pulmonary edema. Let's move forward one more time. And as the edema gets into the alveoli themselves, then they coalesce and merge into a single band. And they move from, you see, it gets narrower and it gets wider towards the periphery. So now they have alveolar edema. So what about pneumonia? We said that pneumonia represented the largest sector in our setting in terms of shortness of breath findings or persons presenting with shortness of breath. Again, bearing in mind your anatomical structure, rib, lung, you see in the curly A lines. But what happens is that you could either have the lung will start taking on the texture of the liver. And so you start seeing these densities where you see rib, this was supposed to be the rib, this is the shadow of the rib coming down, lung, this is the rib, this is the shadow, and this is now the lung that's looking more like the liver and fluid above it. And that's also seen on ultrasound with pneumonia. And as it progresses, you can also see that it becomes irregular, shredded appearance, and this is called shred sign as it pertains to pneumonia. What about pleural effusion? What will you see? So you know that we spoke about the diaphragm being a very reflective surface. You'll see the liver above, and you'll see the liver here again. If you took your probe and the patient is lying on their side, you'll see lung, you'd see lung here if there's a pathology. So when we look at this side, you're going to see the liver when you compare it to this one, and you're going to notice you see this anechoic structure that actually represents fluid in the lungs. So this patient has a pleural effusion. You also notice that you start seeing the spine, which you're not seeing on this slide. So this patient, this is called spine sign, and it's also representative and indicative that the patient also has fluid in the lungs. So let's look back at another study. They took fourth-year students, approximately 514 of them. They got 20 hours of training, 2 hours of specialized ultrasound training. And they found that their sensitivity, specificity, and accuracy increased significantly when they were applying ultrasound to their clinical examination findings. So you're going to find that in the future, part of our curriculum is now going to include ultrasound in terms of medicine. It's already included in the emergency medicine and maybe included in other specialties like ICU as well. So we're going to take another study, and this is an outpatient setting study where they looked at persons with New York Heart Association classification of heart failure 2 to 4. And these patients were seen in 2011 to 2014. They were given a pocket device to determine if they had curly B lines. And they found that persons who had more than 3 to 4 curly B lines, 1/4 of them were likely to either be admitted to hospital or die. So again, and even in the outpatient setting, one could utilize the ultrasound machine to determine and risk stratify when they need to bring patients in. Other studies will tell you that you can utilize the BNP, but since we don't have it, we can use the ultrasound as a surrogate. So I'll present another case. So this is a patient who was referred to me or referred to the emergency room for shortness of breath and bilateral pleural effusion. And that was all the information that was given to me. The history of the patient was just as such. She had no known medical illness, didn't have leg swelling, didn't have a significant elevated JVD. We put the probe on her, and this is what we found. So she had curly B lines throughout. We already knew that she had bilateral pleural effusions, but we wanted to quantify that. So she had a moderate size effusion that needed to be drained. So this patient actually had a transthoracic cardiac ultrasound, and this is the parasternal long axis, and it's showing that she has a poor squeeze, a dilated left ventricle, a dilated left atrium, and fluid around the heart. So she also had a pericardial effusion. So in a matter of an hour, this patient was already started on high-dose nitrates, diuretics, and was referred to the ICU, and it was admitted actually before her lab investigations became available to us. So let's look at the principles in terms of our cardiac views. We have parasternal long axis, parasternal short axis, apical four chamber, subsidal view, subxiphoid view. And ideally, you would like to know all of them. I would suggest we look at them from a pattern recognition standpoint, but my focus today will just be on the parasternal long axis. So what are we looking for? We're looking for the mitral valve abutting the septum. We're looking at the left ventricular size to make sure that it's less than 5 centimeters. And we're looking at if the contraction of that ventricle is greater than 1/3 the actual size. So again, reminding you of the views, what you see anatomically on a still image. You're going to see the right ventricle, which is the most superficial and most anterior. You're going to see next the aortic root, the aortic valve, the left ventricle, and the left atrium. The mitral valve will be right here, the anterior leaflet. And what you want to see is the anterior leaflet actually touching the septum. So it's going to move up as it opens. And the direction that the valve moves will tell you the direction of the flow. So if it goes this way, that means it's going towards the ventricle, and these valves will flow that way, which means it's going towards the atrium, going towards the aorta. My apologies. So just a few more video clips. So this is what normal contractility looks like. You're seeing the septum, you're seeing the right ventricle, you're seeing the anterior leaflet actually abutting the septum, you're seeing the decrease in size greater than 1/3 of the actual size of the ventricle. Because remember that you don't eject all of the fluid that comes to the heart at a given time. There's always some volume left behind. That's why the ejection fraction is only about 65%. But let's look at an abnormal view. We're looking at this and you're seeing that the left atrium is huge comparison to the actual aortic root. You're seeing that this patient has poor squeeze, and you're seeing that the anterior leaflet barely abuts the septum. So this patient has poor EF. And usually we would utilize an eyeball method to say what the ejection fraction is because we're not cardiologists. And so this will guide in terms of your risk stratification of a patient who presents with congestive heart failure on shortness of breath. So let's go back to our patient. Mr. 56-year-old male, no known medical illness with the swelling all over his body. What was done for him? He was started on oxygen immediately. He was given Lasix, as we typically do in the emergency room, even though we know from the pathophysiological standpoint that the preload is increased, and we're trying to treat that. But we know that the output is reduced, and so the kidneys are already affected, and by doing that, you could actually affect the kidneys even more. So ideally, we should have started the patient on high-dose nitrates if we were considering that this patient had flash pulmonary edema of sorts. I have no issues with us starting ACE inhibitors on this particular patient, but those were started as well. So it just so happened that I was in the emergency room at the time, and I decided to do an ultrasound. And this is the ultrasound of the patient.
And now we can get to the apex.
All right, so this sector is actually missing. That's just a defect on the probe. It's not reflective of what's going on in the heart. I'll play it again so you can see. Bearing your anatomical things in mind again, that you have the right ventricle above, left ventricle, aortic root. And you're looking at this as it opens up. This is the anterior leaflet that should be abutting the septum, which is not. So you know that this patient has heart failure, but you're also seeing that as this opens that the ventricle is collapsing. So this patient has evidence, sonographic evidence of cardiac tamponade. And ideally, we started off managing the patient as pulmonary edema when this patient really needed pericardiocentesis. So what did we do? The patient, after seeing this ultrasound, was referred to Dr. Ramphal. Dr. Ramphal, in turn, asked for a CT. I mean, his blood pressure was okay. His heart rate was marginally okay. Saturation were acceptable. We were able to get the CT scan. He had bilateral pleural effusions. He had some calcification in the anterior of the mediastinum, but you can see the pericardial effusion surrounding the entire heart. So it was reported as the patient having a moderate enhancing lobulated mass that extended into the mediastinum, that had calcification abutting the cardia, that he had lesions in this that extended to the SVC and the inferior esophagus, that a compression of the right atrium and right ventricle. So they reported it as if it was a mass, if it was cardiac tamponade, the differential diagnosis was wide on the report itself. So he was taken to theater from CT directly, and he had a pericardial window. And his reports actually did not necessarily reflect anything malignant, but only inflammatory changes. So again, just going back to sensitivity and specificity and what we typically would do historically, we would say that a patient who comes in hypotensive with an elevated JVD and muffled heart sounds will have cardiac tamponade until proven otherwise. But what about the patient who doesn't? So in 2017, there was a retrospective study. It was 2.5 years. And they looked at 153 pericardial effusions. And they noted that almost 1/4 of them didn't have any historical features. And Beck's triad was at best 19% sensitive. So in our particular patient, when we look at him, the only positive feature he had was an elevated JVD. He didn't have electrical alternance. And by this, we mean that fluid surrounds the entire heart like this, and it starts to swing. So the axis moves from left to right. He didn't have hypotension, despite having collapse of his right and left ventricle. He didn't have muffled heart sounds. They had two different physicians, one of which was senior, who listened to his heart, and that was never documented. So again, relying on our examination findings is sometimes a pitfall, and we have to start incorporating these tools in our exam. What if the patient became unstable and we had to intubate? Then we could use the same probe and put it on the anterior neck and say, well, hey, I'm seeing the tracheal ring. I'm seeing these commutative and reverberation artifact. But what if we're not seeing that and we're seeing two of these? Then chances are we're in the esophagus. Again, it's still applicable in somebody who was intubated and the tube gets dislodged or obstructed. You can go back and look and say, well, hey, I think the tube is in. I don't have to reposition it. And there's something else wrong. Maybe it's the ventilator. Maybe the patient is obstructed and needs to be suctioned, et cetera. So I'm just realizing I'm getting old because I prepared this presentation and I saw this picture and I say, wow, back to the future. So we're going to go back to the future and point of care ultrasound and COVID. How is it applicable? So ideally, you want a high frequency probe in a patient with COVID. And the findings are going to be similar to what we would have seen in somebody who had pulmonary edema. Remember, bearing in mind again that you're going to look for the pleural line. You want to see a smooth line. You don't want to see a line that's jagged or ragged. You don't want to see any fluids under the line. You want to see lung sliding throughout. That's the ideal. But then you start seeing B lines. So early on in the disease, the patient might just have this, a normal ultrasound of the lung. And as the disease progresses, you start to see B lines. And as it progresses even further, you start seeing these consolidation areas and a jagged pleural line and fluid above it. And as the disease progresses, it gets even worse. So one of the proposed, I guess, protocols that exist or was proposed was that, you start to stratify the patient who comes in. They say they have fever, cough, shortness of breath, and you apply the probe. They have normal saturation, normal respiratory rate. And if they have an A-line pattern, which is just the lung sliding, then you can discharge them straight out of the emergency room, straight out of triage. But if they start having B-line, so this will limit how much patients get X-ray, their radiation, their throughput times, persons being exposed, et cetera, taking this arm. But if you take the B-line pattern only, then you know that that patient may have to do an X-ray. And if that patient has symptoms of COVID, they look ill, and they have the confluent B lines and consolidations, then they simply just need admission. So let's retrospectively apply the principles that we have to a patient who presented on September 30th. This is a young female. She had shortness of breath at triage. She had chest discomfort, was talking in phrases. She had a history of bronchial asthma, but had no wheezing. It was documented that she had decreased air entry and auscultation. Her oxygen saturations were 88% on room air. They put on a non-rebreather mask at 5 liters. Her SATs was 99%. The diagnosis, you see it below, rule out COVID-19. So let's assume we put the probe in the patient, and this is what we saw. Rib, no lung sliding. This patient has a pneumothorax, and the likelihood this patient would need a chest tube. So the patient was placed in isolation, and a chest X-ray was ordered. And as you can see, this patient had bilateral pneumothoraces. So again, my recommendation, proposal, suggestion, however you want to take it, is that perhaps we can, incorporate ultrasound. We start from the time that they come in. We make sure they're stable enough. We apply the probe. We look at the pattern that we're seeing. We look for the effusion. We look for these things to kind of help to guide the process. They've even started applying the ultrasound machine in kidney disease. So let's say you take a history and physical exam and you do your point of care ultrasound. They don't have lung sliding. They have a pneumothorax. They have B lines. They have pulmonary edema. You go above the diaphragm and you see anechoic structures. They have a pleural effusion. I can't tell you how often we have found persons who have uremic pericarditis and end up with a massive cardiac effusion, pericardial effusion. Maybe they have poor diastolic or systolic function, then they have heart failure. And if you look at the IVC that we haven't mentioned yet, if it's plethoric or it's not moving with respiration, then that patient has diastolic failure. So even internal medicine has applied for a study where they're looking at how ultrasound can affect their throughput as it relates to patients who come in and compare it to those who didn't get ultrasound. But the results are not yet. The study was just registered in January 2020. So take home points. Let's look at the fact that the ultrasound is a portable device. Let's look at the fact that it can guide the pathway with patients with shortness of breath. It's better in terms of your inter-observer reliability. You don't have to radiate the patient and may limit exposure to some extent. The learning curve is not as steep as we would like it to think it is. And the goal ultimately with us, at least from an emergency room standpoint, for persons who didn't do sonography as their first degree or radiology, our goal at that point would be just for pattern recognition. These are my references, and I thank you for listening, and feel free to ask any questions.
Thank you, Dr. Roper, for that presentation, and thank you for going through the basics of ultrasonography for us, and also going through this case series of evaluations for probably one of the most common presentations we see in the emergency room, which is shortness of breath. And so we have a lot of excellent presentation, Dr. Roper, on the use of ultrasound in the emergency room. Great presentation, excellent presentation. Thank you for the presentation. Awesome presentation. And thank you for incorporating the outpatient use of ultrasound as well. Brilliant presentation. So while we wait for some questions to pop up in the chat amongst all the congratulations, do you think, Dr. Roper, that this is something that could be of benefit in the Family Islands and outpatient clinics? Do you think it would affect morbidity and mortality?
Absolutely, 100%. I would say this. I purchased a butterfly ultrasound. It's almost a year now. I did air ambulance for a year and a half. And I can tell you that sometimes the history that we get versus what we pick up, it's as wide as north is from the south. And so I think some of the decisions that can be made if the person knew what to use or what views to look for, we can say, do this and do that to temporize the patient. And perhaps maybe even make interventions in terms of clinical management, drugs that you can give based on what we're seeing. And it may limit the number of patients who actually have to be airlifted or the actual intervention itself. So I think the whole world is moving towards ultrasound. We're just a little bit behind the eighth ball. And so, yes, it would be of great benefit to the Family Island, even if it is that they're just sending the video and the images and we're looking at it to kind of guide the process of their management.
Thank you. And we have a question here. For the patient with cardiac tamponade, did you go back and listen to the heart for muffled cardiac sounds?
I didn't, to be honest. The thing is that here it is that at that time, I think I had just finished DM, and the person who was listening had just finished DM for internal medicine. And so it was kind of pointless for me at that point to go back and listen to the chest if I saw the sonographic findings. And for them, they were of the opinion that the patient had severe vena cava compression. So we were both arguing with each other as to what do we do with this patient? And ultimately, Dr. Ramphal was the tiebreaker.
Okay, thank you. So we have a lot of brilliant presentations, very informative, excellent, amazing, enjoyed. We do not really have that many questions, but it was really a very, very insightful presentation, Dr. Roper, and it just got me into thinking, is this something we should be thinking about moving forward in terms of handheld ultrasounds?
Absolutely.
On every shift, we should have someone who might be trained in handheld ultrasonography, and not just for the emergency room physician, but maybe even for a physician on every specialty?
I think that I think in the US, they have subspecialty programs for ultrasound. I'm not sure if medicine can navigate from internal medicine to ultrasound. But if you see in 2020, they're already doing studies, that means they've already incorporated to some extent into their programs. And so I know that we have it as our subspecialty in emergency medicine. Whether or not every specialty, I don't think it's applicable for every specialty. I think that maybe radiology to some extent may have to do subspecialties in maybe lung ultrasound or cardiac ultrasound, because we don't really have an echo technician readily available. In a first world setting, you can call somebody to come out and do an echo, So I think ideally it would be good if everyone could do ultrasound, but I doubt that will be practical in our setting.
Okay, thank you very much for that. Dr. Brown would like to say well done, and he's very supportive of point of care systems that can facilitate our improvement in care that we administer daily. Dr. Deanna Bain would like to ask a question. Go ahead with your question, Dr. Bain. You can post it in the chat or you can send it to me and I will read it. We have another question here from Dr. Roberts. Any handheld ultrasound reasonably priced, because cost is a very real issue in our institution?
So I purchased the butterfly system because it was the cheapest one. But the challenge is that they're going to be maybe close to $2,000. But you get what you pay for. And so the gray images and the dark images don't look as crisp as an LG would, and an LG would cost maybe upwards of $5,000 to $10,000. So realistically, ideally, an handheld would be good. But if you had a machine on, let's say for medicine, a machine for surgery, then it negates the fact of having handheld, and everybody will be on the same platform, and everybody will be talking the same lingo, and there wouldn't be an issue as to, you saw this on your machine, I didn't see it on mine. And so I think that would be perhaps the better route to go in an institutional setting. I think the greater challenge would be converting what you would have had, because we're still manual in terms of what we write in the notes. It's not actually uploaded in the system of any sort. And that might create a challenge in terms of a store buying for the images that you actually produce or took.
Okay. And we have Dr. Conliffe, who would like us to remember handheld ultrasound was used in the Dorian shelters by Project Hope and proved to be a very useful adjunct for clinical management and referrals to the emergency room. Dr. Bain was saying her question was related to Family Island physicians using these studies and how to formulate a proposal for DPH to both purchase and train our physicians in the area. I think you kind of touched on that, but you could make some comments.
I will say this. There are so many videos on the learning that you get, even from medical school to the point of when you finish. What the book knowledge is far different from your clinical knowledge. And again, it's all going to be pattern recognition. And so I would say that I would argue that if you have a machine, YouTube, half the times of most of what I've learned is really through YouTube. And then I went on to do the course just because I was going to invest in the machine so that I could continually train myself as it pertains to, what the images look like and what the patterns look like. So while I think we could use machines on the Family Island or maybe at some of the clinics, I think the training part of it, getting the book knowledge and then doing the practical, you would still have to do some learning on your own and dedicate time to actually hone in your ability to do scans.
Okay, well, thank you very much, Dr. Roper, for agreeing to speak with us this morning and doing this M&M for us and highlighting how shortness of breath can present in so many different diagnoses. There aren't any further questions. Okay, I see. Okay, some more questions. What would be research priorities? Would you be able to comment on that?
In terms of research, I think we can do it, but I think in our setting, you would have to have a digital platform where you are storing the images. The manual way of storing the images still will become an issue because in terms of training, let's look at ACEP. They'll say you need to do 30 scans of the chest, 30 scans of the heart for you to be considered proficient. Somebody starting out, they do the scan, they save the images, they still have to produce those images to someone who is trained to verify that they're doing it correctly. So I think we're a little bit ways off in terms of saying, whether or not we can do studies. Certainly you can incorporate it into common practice now, but doing the studies may be a challenge because I don't think there's anybody who did a post-DMN ultrasound. So there's no measuring stick to guide the actual person doing the scans.
Okay, thank you. And Dr. Deanna Bain just responds back, training in handheld Dopplers or your handheld Dopplers would reduce the frequency of cost of care as it relates to unwanted air ambulance calls with incorrect diagnoses, which you had highlighted before as well.
I agree 100% with that.
Yes. So if there are no further questions, we will say thank you very much, Dr. Roper, for joining us today and presenting to us. We are very appreciative. And thank you to you, our audience, for your participation and your attention. And thank you to our IT specialist, Dr. Darren Halliday. So like I said, once you do the feedback, the certificate will populate to you when it becomes available. All the CMEs will be ready before the December 31st deadline. We already have issued 8 CMEs for the year. There should be 9 issued by the end of next week, and we have 2 more to add on to the 5 issued by the end of next week, additional, sorry. And so this meeting this morning with Dr. Roper is the last of 2 for the year, and our last CME will be next week, Wednesday, and that will be Dr. Deshawn Ferguson Saunders, and she will be presenting on the PMH experience of the pediatric multi-system inflammatory syndrome, or COVID-19 experience. And Dr. Wells sums up everything at the end. Awesome job, Dr. Roper. So thank you very much, and we will see you guys next week. The key, Dr. Isaacs, is oxygen. I see you're asking for the enrollment key. Oxygen, all lowercase.
Thank you, guys. Be safe.
Thank you.